So, next I'd like to introduce Dr. Pradeep Kumar, who is a consultant geneticist here at KMCH. Actually, he needs no introduction in this field. He is known all over India for his field, and he is also very prominent on social media. He has his own YouTube channel as well. He runs many parental support groups for Down syndrome, storage disorders, etc., and many awards and scientific papers as well. So, welcome you, Dr. Pradeep.
Thanks, Dr. Vinod. Those it, I would like to thank the organizers for Indian Association of Cardiac Imaging, office bearers, and congratulate for this wonderful event. Thanks a lot for inviting. So I should thank the previous speakers, Dr. Rajesh Kansar and Dr. Priya. They have set the stage for me. They have given enough introduction about genetic disorders, genetic association with cardiomyopathy. So everyone is now provoked when to start doing genetic testing in cardiomyopathies. I hope the time will come when we won't think about whom to test, because the cost is the criteria now, and it is a limiting factor. Over a period, if this cost comes down, it will be like ordering an echo or an ECG. You would be ordering genetic testing, and then you will get so much of information. I would like, my talk for another 20 minutes will be about the basics of genetics of the cardiomyopathies, and where this genetics and heart muscle meet, and whom to test for genetic disorders, and what are the uses of doing genetic evaluation. So the end of it, I would convince you, I hope I will convince you that everybody needs a genetic testing, because that is my job again. Genetic workup, we start with index case workup. A patient who comes in is our index with the complaints or findings, and then we try to establish genetic diagnosis. Not only clinical diagnosis, we will fix it. The genetic diagnosis, nobody questions it. So treatment options will be considered based on the genetic evaluation, the diagnosis made, and at-risk family members will be screened. If in case there is an expected recurrence in next subsequent pregnancies, we do screening for the parents, and then screening during pregnancy, testing during pregnancy, by prenatal diagnosis, by chorionic villus sampling or amniocentesis, reproductive options if nothing is working out, and then delivery plan and following up the baby, so that we make sure there is no recurrence of any genetic disorders. And etiologically, here comes the question, where should we start doing genetic testing? Because cardiomyopathies can be multifactorial, or there can be some genetic predisposition, like double hit hypothesis Dr. Priya explained. So they will be predisposed for getting cardiomyopathy, but exposing to certain environmental hazards, they get, not like 10 people they are getting exposed to same environmental hazard. Somebody will be more prone for cardiomyopathy. This is that overlap of genetic and multifactorial factors and pure genetic variations, where a single gene, a responsible single gene, plays a role. Here is the gray area, where to do testing, whom to decide whether they are into genetic or this is going to evolve. Now I am thinking in terms of multifactorial, like Dr. Vinod was discussing about a viral myocarditis, whether it is subclinical. I don't know if this cardiomyopathy is due to viral myocarditis secondary consequence. But again, over a period, we will be doing all these testing. We will know which is evolving into what. So to know what exactly the genetics mean, we cannot go directly do a gene without knowing the basic idea of where the gene is located. So we stand as a human being here when we split our whole body into tissues, cells, nucleus, and inside nucleus there are 46 chromosomes. These are basics, 23 pairs of chromosomes, 23 from father, 23 from mother. Chromosomes are just containers. They contain genes. They have around 23,000 pairs of genes. So each chromosome may contain hundreds of genes. If you unwind that big ribbon of that chromosome, you will see multiple genes in that. So we are more focused on that single genes. So cardiomyopathy is concerned, don't worry about the containers, always worry about the genes inside. So this is how we unwind and see. We can see the genes are located in that ribbon, and that ribbon is coiled into one chromosome. So DNA is just the gene is made up of ATGC sequences, just codons, just some poems written on a ribbon. So body will read this DNA, mRNA will read this and produce a protein. So this is the basis of abnormalities that happens in the tissue level. So one gene, one polypeptide hypothesis is very, very famous. That means one gene will be responsible to produce one protein. Roughly, you can take it that way. So if that protein is needed in particular cell or an organ, if that gene is not functioning properly, this protein is not produced properly, and because of that inaction or altered action of that protein, the organ or the tissue will be damaged. It cannot function properly. This is a basic. And so this just gene is a quote, words full of wisdom that someone important said. We don't know who it is, and can make the reader get inspired, and the inspired reader is mRNA. It gets inspired and produces some protein. So what goes wrong? It is just a spelling mistake. Genetic abnormalities, what we see, are just spelling mistakes of that spellings or the poems written on that ribbon. Because of the spelling mistakes, mRNA is unable to read it properly. Proper protein is not produced because of that spelling error. So this is an example. A man without her, man is nothing. A woman without her, man is nothing. This means woman is superior, and when you just alter with a comma, a woman without her, man is nothing. This means man is superior. It's just a spelling mistake. It changes the whole meaning of the sentence. If the meaning is changed, proper protein will not be produced in the body. So isolated cardiomyopathy, there are two types we always think of or see: isolated and associated. What does it mean by isolated? Isolated is just cardiac muscle is involved. Associated means other organs can be involved. So isolated, there are so many genes involved. Where do they work? They work here in the cardiac muscle. These genes are responsible to produce proteins which helps cardiac muscle to function properly. If these genes are not produced, these genes are defective, these proper proteins are not produced, because of that cardiac muscle is not functioning. One gene, if it is altered, the protein will not be produced. That protein is needed for maintenance of the cardiac muscle. Because of this gene, this protein, cardiac muscle is affected. So this gene is expressed only in heart muscles. Because of that, the heart is involved. There are so many other group of disorders where the gene will produce a protein. That protein is needed in various organs or tissues. So cardiac abnormality is part of it. There will be so many other manifestations where and all the protein is needed. You will see the clinical manifestations. This comes under inherited syndromes with cardiomyopathy. Cardiomyopathy is a feature. There are so many other features like your Duchenne muscular dystrophy. This is needed in your skeletal muscles, sometimes in the brain, the behavioral problems. They have neuromuscular disorder, so mitochondrial disorders, Friedreich ataxia, presentation is with ataxia, amyloidosis, multisystem abnormality, Dannon's disease, and Noonan syndrome. All these are multisystem abnormalities where cardiomyopathy is just a feature. This is the difference: single gene and associated syndromic cardiomyopathies. So genetic evaluation, this is whom to do genetic evaluation. We see this, we have this ACMG guidelines. It says everyone has to undergo. Genetic evaluation is indicated with the cardiomyopathy diagnosis. Why is it so? Because to assist in patient care and management of at-risk family members. Unless you know whether it is genetic or not, you cannot prevent a recurrence in the family. But there are no clear-cut guidelines, clear-cut criteria to whom to do. All these are evolving. We are just in the gray area now. So there are so many algorithms to go about where to do genetic testing and all. All these are available in theory is more available everywhere. In short, I can say a family history of red flag signs or family pedigree showing abnormalities. But you cannot always depend on that, because this is the first generation. The disease would have shown up. Autosomal dominant disorders never always completely penetrant. All the other persons will be silent. Maybe at 60 years you are seeing cardiomyopathy. 70 years they would have, if they wouldn't have gone for cardiac imaging, they wouldn't have been diagnosed at all. And the next generation, the presentation may be little earlier. So this, you will think this is the first generation. We will be missing them. So at least 3 generation family pedigree, this is what they expect, but again, not always present. Sudden cardiac death aged 50 years, sudden infant death syndrome, unexplained syncope, particularly if it is during physical activity, heart transplantation, the absence of coronary artery disease, presence of a pacemaker, all these histories, these are there, but again, the presentation is totally different in many other families. If you see this family, you can see the first abnormality of cardiomyopathy. This happened at 55 years, this person, and his son, he's just screened. He is not symptomatic because he had mutation. The son and daughter were screened and daughter was negative, and son had this mutation. He was asymptomatic. 2 years later, he went in for sudden cardiac arrest and transplantation. See, this is the first person, but previously there were many deaths, sudden cardiac deaths. in our generation, in our population, if you ask beyond 2 or 3 generations, they will not have any history. They will not have any details or any reports of previous deaths. All these are considered as heart attacks. They won't have any idea of what has happened. And look here, this person also sudden cardiac death, son is affected, and this person who died, he had cardiomyopathy, son is affected. You do this testing, complete testing for one particular patient and apply the same mutation for others and see who is positive, who is negative. You can divide the family into two. Who's having that mutation, who's not having that mutation. Who's not having the mutation, they can relax, they're not going to get worried. Who's having the mutation, they have to be under surveillance, under follow-up with a cardiologist. So this will help further another unexpected event in the same family. So we do a pre-test counseling extensively. We tell the family, counsel the family about the need for testing and coverage of each test. They will be spending from their pocket. They expect all the time spending. I want to get results. Sometimes we land up with variant of uncertain significance or negative results. This depends on the coverage of the test. What gene you are looking at, what group of genes you are looking at, what test you are ordering, and the capability of the lab, and what is the coverage pattern of that lab. All these things decide on getting the positive results, and implications with extended family members has to be explained. Sometimes they take it in a positive way. Okay, I'm going to know about all these things. We will be safeguarding most of them, but sometimes they'll be paranoid, they'll be phobic. If somebody turns out to be positive, what we are going to do? Till now we don't know about our status. Later on, what we are going to do with this mutation in our hand. So all these needs proper counseling. Need for further level of testing has to be explained to them. If this is negative, what is my next level plan, and costs involved in the testing also. So cost, coverage, accuracy, fallacy of the investigation, and who the team also. Team, not only the doctor's team, but the lab team also is very, very important. Their competency matters a lot. So you leave all these. There are a list of testing available now in India. Leave all these, karyotyping, fish, or all these are not needed for cardiomyopathy. All other cardiac disorders, okay. But cardiomyopathy is concerned either single gene testing. You know it is a syndrome, say Fabry's disease or Pompe's disease. You know a syndrome. You know one particular gene. Go for that gene sequencing. Or if you don't know whether it is which gene I'm looking into, I know this group of cardiomyopathy, then go for gene panels. If you don't know, you want wider coverage, clinical exam and whole exam, depending on your need, you can order. But the only thing is you have to go for single gene level testing, either single gene manually or next generation sequencing. Post test review and counsel regarding the test implications, mutation if it is identified, risk assessment and of at-risk family members, putting this person into surveillance, extended family member screening, and bringing them into surveillance with surveillance protocol with the cardiologist. If particularly this one, this we are getting quite often in Indian population. Right and left we are getting variant of uncertain significance. Most of these filtering work has to be done at the lab. So I saw Dr. Priya's presentation. There are so many variants they are giving. We will talk to them again. We will try to filter the mutation. It is a big headache for us, as mentioned. Getting so much of VUS, whether it is applicable to the parent or not, we don't know, because variant of uncertain significance are just non-actionable variants. You cannot label a person with the variant of uncertain significance. Next level of genetic testing may be needed, because this result wouldn't have covered that particular region. You are looking for somewhere, it is hidden again. Family segregation analysis. 2 persons affected, one cardiomyopathy you check, and he has a variant of uncertain significance. You can check that variant of uncertain significance in the other person, see whether it is matching or not. If it is not matching, this is not a mutation you are looking for. You have to look for something else. And functional studies, based on the findings, you can recheck the person whether the same findings are applicable or not on clinical follow-up. All these things are needed for variant of uncertain significance before labeling. This is a big headache nowadays. So we'll move on to the case scenarios, and then I'll stop my talk with a final note. So clinical picture: 33 years old, healthy male. He had sudden cardiac arrest. Family history, no. Everybody was fine, and this person suddenly went in for cardiac arrest. Revived on evaluation, is found to have arrhythmias and cardiomyopathy. This is the clinical picture given to us, and test performed was sequence analysis and deletion duplication testing of 150 and odd genes, and the finding was this. So RYR gene, there is a pathogenic mutation, heterozygous mutation. The family is more worried about his sibling, and also we are worried about the parents as well, because we don't know whether they are silent carriers. All these persons were normal, even his parents were normal. because this could have been de novo mutation that has happened only in him. Parents are not carrying autosomal dominant de novo, only the gene is mutant in him. But again, we cannot stop with this because he's 33 years old. He will plan his next offsprings, and then there can be a chance of 50% because he is a carrier. The recurrence risk is autosomal dominant, 50% carrier status is there. That all these things has been explained to the family. Here, no family history, 33 years old, sudden cardiac arrest. So same way, this is another child born to 4th degree consanguineous, family pedigree, few neonatal deaths of unknown cause, index child apparently normal till 1.5 months. 1.5 months, sudden acute febrile illness, sudden respiratory distress, sudden cardiogenic shock, evaluated dilated cardiomyopathy. So no family history of cardiomyopathy as such, but 1.5 months it presented with dilated cardiomyopathy and cardiogenic shock. No external genetic markers suggestive of some syndrome. So genetic evaluation, again, mutation is found. Autosomal dominant mutation, there's a pathogenic mutation, likely pathogenic variant, and it means that the child has got cardiomyopathy. It is a genetic cardiomyopathy. So what next is autosomal dominant? We expect family members, maybe they may be carriers. Father's echo was recently done, it was normal. Mother's echo, immediately you do that and come back for early signs of cardiomyopathy. Then genetic mutation will be done for the family members. 1.5 months old, first baby, so definitely they are going to plan next pregnancy. For next pregnancy, for prevention, we need family evaluation and then prenatal diagnosis in the next pregnancy. Where this TNNT2 gene is there, it is there. It is responsible for the maintenance of your cardiac muscle. So this one, child diagnosed with dilated cardiomyopathy and motor delay, but again genetic test was not offered immediately. Born to consanguineous marriage, was diagnosed with motor milestone delay. They came to us for pre-pregnancy counseling. The child was treated as motor milestones separate, and this cardiomyopathy, they thought it was some post-viral dilated cardiomyopathy or whatever it is. They were thinking in terms of that. But knowing two different symptoms, and we don't know whether it will connect or not. Particularly, family was worried about recurrence in the next pregnancy. We tested the index child and found out a mutation, which is a homozygous mutation, which means it is autosomal recessive, primary carnitine deficiency, and we fixed that mutation. Parents were checked and they were carriers of the mutation. That means there is a recurrence risk of 25% in the next pregnancy. Prenatal diagnosis in the next pregnancy can be offered to them. 70% expected normalcy. We will tell them whether baby is normal or not, and then this child also will be treated with carotid supplementation and cardiologist follow-up. So this is how we will evaluate and give a final diagnosis, even though it has been considered as maybe a sporadic event. So again, another baby born of consanguineous marriage had floppiness. Here again, motor milestones delay. Previous baby, motor milestones delay. Here again, motor milestones delay. Normal intellect, hepatomegaly, floppiness. So and then baby had hypertrophic cardiomyopathy. Obviously, the diagnosis is Pompey's disease. So they present with hypotonia, hepatomegaly. They will have motor milestone delay along with that cardiomyopathy. Most important thing is these disorders are treatable nowadays. Enzyme analysis was done. Genetic analysis showed homozygous variant in GAA gene. That is a pathogenic variant that confirmed it is Pompey's disease, and this child is on enzyme replacement therapy with glucosidase alpha. That is enzyme replacement therapy recommended, and receiving past 1 year. We have arrested the disease. Baby walks with support. Cardiomyopathy is under control. No progression of the disease, and she is under rehabilitation. We cannot stop with that because the family was planning next pregnancy. This autosomal recessive disorder, 25% recurrences, and parents were checked. Fetus was also checked, and fetus was normal. So now we started treatment for the index child. We have prevented or made sure the next baby is normal also. So another group of lysosomal storage disorders, 3rd degree consanguineous, coarse species, developmental regression, hepatosplenomegaly, dermal melanosis, and cardiomyopathy. Obvious diagnosis. The group is mucopolysaccharidosis. With the findings, clinical findings, we think of Hurler type 1, and urinary gags were elevated, and enzyme analysis was deficient, confirming Hurler's disease, and treatment options are available. Unfortunately, this patient we are unable to give. They are referred to other center, and enzyme replacement therapy option is available for this Hurler disease type 1, and autosomal recessive disorder, 25% is the recurrences, and again parents were checked and prenatal diagnosis was offered for this family. So Duchenne muscular dystrophy, we have talked enough about it. Again, this is becoming treatable now. So, well child till 5 years of age, male child, X-linked recessive disorder, tripping, falling. You all have seen patients with this, even in undergraduate posting. So, calf muscle hypertrophy. Most important thing is X-linked carrier, X-linked recessive carriers will be mothers. So, counseling is very, very sensitive because you are going to label a mother if in case if she is a positive one, and you can end up with a broken family. It has to be very, very sensitive, and so it has to be taken care of. So deletion duplication is a testing option available, and gene sequencing also we can do for DMD depending on the results. So management is steroids. Steroids not only improves the, not only prolongs the walking period. It hampers, it stops the muscle weakness progression, and not only there, it acts in the heart muscles also. It actually prolongs cardiomyopathy. So we expect cardiac abnormalities by 10 years of age. But again, cardiomyopathy to show at 10 years, there should be some pathology happening before that also. So the concept now is we have to follow these children from younger age, so that initial stage itself, the changes occurs, we can start them treatment, because preserving them till they get treatment is the concept nowadays, because exon skipping therapies are available, gene therapies are available for Duchenne muscular dystrophy. So till then, these children has to be ambulant. The cardiac irreversible damage shouldn't happen. So start early monitoring, usually picked up at 10 years, but that is not enough. Pathology starts well before. So echo-wise, we will follow up global longitudinal strain and fractional shortening is what we expect from the cardiologist, and maybe MRI may be needed, but it cannot be done frequently for these children. Medications like perindopril to be considered early to prevent irreversible cardiac damage. So sum up, red flag signs or family history, young age, unusual presentations, associated findings, offer genetic evaluation as indicated. But again, over a period of time, once the cost comes down, I'm very hopeful that this test will come into first line or second line of testing. There won't be any question about doing genetic testing or not, because it has so much of implication in the families. Pre and post test counseling is very, very important, because making this family understand why we are doing, what we are going to get out of this testing is very important for the compliance and the basic understanding. Otherwise, either they won't do, or they will do and get so much of pain and tension and anxiety after the results. So risk determination for index patient and also family members, anticipatory guidance, evaluation of at-risk family members, better surveillance and better management, definitely genetic workup is going to help us with. And prevention future pregnancy is very, very important. Familial and syndromic cases, definitely carrier screening is important. You see whether this will manifest very early in life, then prenatal diagnosis can be done. Chorionic villus sampling or amniocentesis, pre-implantation genetic diagnosis coming up in a big way. And if nothing is working, maybe donor options in mitochondrial disorders or sperm donor also can be taken as an option. Thank you so much. Any further questions, I'll be happy to answer.
Thank you so much. That was an excellent talk and gave us a lot of insight into genetic testing. Any questions from the audience?
Hi, thanks for the insight. I just wanted to ask from a public health perspective that do you believe that if there is a pandemic, epidemic scale myocardiac cardiac diseases which you think can be addressed at a national level with early stage genetic testing, and it's done on younger population, and probably it leads to a scenario where like tuberculosis was eliminated, so some of the cardiac diseases at a national burden level, cardiac disease burden can be addressed.
True. To take it to a community level, we need informations, we need short pilot studies at least, and now we are fighting with so much of rare disease. This is applicable for any other rare disease what we are dealing with, not only for the cardiac related to genetics, anything, any other rare disorder which is in the population, like spinal muscular atrophy. There's a big boom about all these spinal muscular atrophy, 16 crore medications and all. We don't know what is there in the community level. Definitely, we in Indian population need so much of study, research to know at least these preventable disorders, preventable abnormalities which is carried through the generations. But again, the priority of when we go into community and the government, the priority of government is little different from what we, because I am a geneticist, I'll be more concerned about genetic disorders. These are in 1 in 5,000, 1 in 10,000. They are fighting with even anemia and tuberculosis now. Comparing this, putting so much of money into your project, comparing to this one, this is the need of the hour, this is what, and things are slowly changing. The rare disease policies are slowly changing. The parental organization groups are working with the health policy makers, and I hope this research will come up in future and we will definitely get better idea in our population.
I have two questions, Pradeep. First one is like, suppose you have a patient of like hypertrophic cardiomyopathy. You know, there are cardiomyopathic genetic panels, all companies have that. So do you order that panel, because we have to think of the cost also. So will you just order that panel, or you just straight away go for whole exon sequencing or whole genetic sequencing?
Yeah. Now it is like we have to compare between the coverage of that panel, coverage of clinical exome, and coverage of the whole exome sequencing. Cost wise, the difference will be 5,000 each. You can take it as, if the panel is around 12,000, it will be 17,000 and it will be 22,000, like that. So it will be just 5,000. If we are very clear about what genes we are looking for, say hypertrophic cardiomyopathy, you are listing out all the genes, we have to talk to the lab. This homework is needed, because you cannot write left and right, do the testing and give before understanding. Your gene will be one particular gene in your mind, that coverage will be very low in a panel. So we have to talk to the lab people. I want these genes. What is the coverage pattern? Invariably, they'll say 100%. But again, if you know that, if they know that you know genetics, you can talk to them. No, I know it is not completely covered. Tell me what is the deletion duplication percentage you are missing. All these things, you get the information, then put forward. If nowadays we are, previously it was like panel is like in-depth looking into 150 genes. Nowadays, the same coverage is given in clinical exome and whole exome. If you are looking for some rarest of rare gene which is not covered in your panel, obviously you have to go for clinical exome or whole exome. Now we have moved to clinical or whole exome, not doing panels nowadays because of all these reasons. But again, if panel gives a better coverage than clinical exome in certain genes, I would go for panel.
Okay. One more question. I don't know if the time is there. So suppose you have an index case who is like has a pathogenic variant, then you go for the cascade screening. Suppose his brother you're doing. So if he has the mutation, obviously you have to follow him up. So if he doesn't have the mutation, you don't. Usually for a screening of the family, we do an echo and ECG yearly like that. So if that guy doesn't have the mutation, can we stop screening him?
Yes, you can reassure him. He is like any other person from the population.
But suppose the index case has a variant of uncertain significance.
A variant of uncertain significance, we won't apply at all. I won't apply personally. I won't check that variant of uncertain significance to the sibling.
Okay.
Because we are not sure in this child itself. You cannot put that uncertainty on the sibling also. So unless we are very sure about this mutation in this guy, you cannot extend the family member's search.
Sometimes the variant of uncertain significance will have the clinical features of cardiomyopathy like that index patient. So in that case, can you go and do it for sibling, and if he gets the same mutation?
There are also clinical follow-up only, I would advise. Okay. Not the genetic labeling. We need so much of information. So before you do that, make sure that genetically it is strong. It means that either that should be the mutation, because we don't have the evidence. We are thinking in terms of variant of uncertain significance, or in case if that mutation you are looking for is in the uncovered region of that gene, and this is the best that lab is giving, you are missing on that pathogenic variant, you are looking for going ahead and doing this one in all the family members, putting them into unnecessary confusion or anxiety. So VUS are non-actionable variants. Please, that is the final word I would give.
No, I think I'll just send the patient to you. That will be easier for me.
Sir, but is that right, that in case if you find VUS, for example, we start doing more testing, and VUS, what is reported now, will become likely pathogenic for the other patient. That is what.
Yes, ma'am. So at present it is a VUS. That is the right word. At present it is a VUS. Maybe you can ask the lab people to look into, reinterpret the analysis over a period. After a year, the database, the common database, yes, would have been updated. There would have been so many reported cases. Then this can become likely pathogenic later on. But again, at present it is VUS. Don't act on it.
Building database.
Yeah, building database and rechecking quite often. maybe ask the family to come back after a year. You ask the lab to do rechecking analysis, and then you can go ahead. Or we will check some, all the databases are not uniform. All labs databases are not uniform. We sometimes check in prenatal setting, ongoing pregnancy, emergency, we cannot wait. We check this data with another lab, their database. Sometimes they give it is a pathogenic variant also. Or we have some database softwares we have with us. We will check on our own whether it is falling into pathogenic or likely. So viewers need so much of work. That's so easy to count it.
Any other questions from the audience?
Thank you.
Request Dr. Ashita to come forward and felicitate Dr. Pradeep.
Thank you, sir.